So I was asked to talk about ultrasound. I couldn't think of a better title. Okay, so Allison Reagan asked me to come over. She asked me to talk about nerve blocks, things like that. And basically we kind of just went back and forth about kind of procedures that you guys do a lot and that you'd like to do. So we decided to talk about, I don't know, I've got 4 up here. I don't think I'm going to make it through all of them. We'll probably just kind of focus on the first 2, which are things that you guys do pretty commonly. You guys know this guy. He came in yesterday, maybe the day before that too. He comes in, he's got pain over his shoulder. It looks weird. He's got a C5 palsy, or C5 sensory distribution problem. And he comes in, and this is his x-ray, right? Right? No, guys, wrong. Right? That's a posterior dislocation. Jarrett was the only guy who got it. All you other guys failed. Right? This is what it's supposed to look like. Remember? Because you were looking at the scapular Y right here. This is going to be the actual AP view that you want to look at. And you can see it's basically an anterior dislocation. It's in the subcoracoid position. So we always want to go ahead and basically when I was training, what we did was, we went and sedated the person. Eventually we got Untitled CO2 on board, and then we ended up started doing all these blocks. When I first started doing these blocks, the orthopod started making fun of me my second year because they were like, dude, you can't hit the glenohumeral joint, are you kidding me? I found that it's actually a little bit more difficult than they would actually admit to. They're probably missing a lot of the time, judging by the screams that you hear from room 5 of CCT. So anyway, what we're going to go through is just kind of like how we're going to end up getting into the glenohumeral joint. So some of you have done these with me, some of you haven't. Some of you have done these basically with the shoulder study. But essentially what you're doing is you're placing the ultrasound probe in the posterior position on the back. What you should be looking for are kind of 3 or 4 big kind of regions. We're not going to get into kind of like more fine-tuned kind of stuff. But essentially you're going to look for the humeral head, the glenoid, which you can kind of see this little hyperechoic kind of area right here that kind of comes out. And obviously you can see the glenoid make an articulation with the humeral head. And if you notice this big bright white line right over here, that's the infraspinatus tendon. If you ever have problems figuring out where you are, basically when you're doing this kind of procedure, just do this. All right? The infraspinatus externally rotates the shoulder at 0 degrees of adduction. And so you'll be able to find and you'll be able to basically follow your infraspinatus tendon all the way out to the humeral head. And that's pretty much a fairly safe way of finding where your humeral head is at. Of course, unless you end up having a full thickness tear of your infraspinatus tendon, which you'll have some, but you won't have basically the tendon completely unfolded off the bone. This is what you're going to end up seeing pretty much beforehand. Now you'll notice in this picture that this is a linear probe. Obviously that's going to be used on thinner people. This is a curvilinear probe, which is going to be used on bigger people. And so you're seeing these exact same landmarks right here. You're seeing here the glenoid, but now you're seeing this hyperechoic line right over here, which is the humeral head. And then if you kind of just still kind of hold true to that thing that I was telling you about with the infraspinatus tendon, follow that bright white line, and here it kind of goes down, and it just kind of falls off a cliff. And that's how another way that you can kind of help yourself to find where your humeral head is, because I find these to be a little bit difficult. Now, just in terms of a little bit of orientation, remember these are anterior dislocations. Your probe is posterior. So this is actually anterior on your patient. This is posterior on your patient. This is lateral. This is medial. I hope you can get the last parts. And this is your joint space, this little black area right over here. And when we end up doing these intra-articular lidocaine blocks, this is essentially where we're kind of going into, and this is pretty much how we're aiming. And pretty much when you're injecting into the actual joint itself, the joint and the actual sticking the needle into the space, that's really not the hard part. I know you guys know how to do that. You've done ultrasound-guided peripherals, you've done ultrasound-guided centrals. Basically, sticking a needle in the place where you need to go, that I don't really feel is the actual kind of caveat. That's not the mastery of this drill. The real drill is actually just learning where you need to go. And basically what you're looking for is that hematoma which is right around the area of the glenohumeral joint. And this is pretty much coming in with the needle. Now, word of caution, when you do these, again, some patients will be a little bit bigger than others. So when you end up having these bigger patients, you'll probably want to use a 3.5-inch spinal needle, just because of the fact that even the 18-gauge needles will probably not reach. So you'll end up feeling a little disappointed in yourself and a little bit short. And so you may just not reach all the way. So it's probably going to be important to use a little bit of a longer needle to kind of get into the space. And so when you end up reducing your joint afterwards, you can see now that you end up having this. Here's your humeral head. Here is going to be that infraspinatus tendon right here. And this is going to be your glenohumeral joint. And this is essentially what it should look like kind of when you're done and when you're post-reduction. And that brings you to the next kind of caveat. One of the things that we, again, used to do back in the day, I guess the mid to late 2000s, is we sent all these guys back and forth to x-ray over and over and over again. What you can do with some of these is get in the habit of using the ultrasound to assess the adequacy of your reduction. You can do this with fractures too. But one of the things that you can do is you can just place your curvilinear probe or your linear probe, depending on the side of your patient, and then you can check and see whether or not you've got your humeral head in place, whether you've got your infraspinatus tendon that's kind of running, well, not right there, but right here, just running over to your humeral head, and then whether or not you've got a nice articulation humeral head and glenoid. Does everyone see that? Is there any questions? That's really, really easy. And you guys probably all should be doing this. There's just a couple caveats with anatomy that I think you guys need to understand in terms of when you do this, that basically I ran into pitfalls when I first ended up starting this procedure. First pitfall is the plane of the scapula, right? It's not at 0 degrees in the coronal plane. This plane of the scapula is actually off by about 30 degrees. So remember, when you end up making that injection, you actually need to come from an angle. Otherwise, what you're going to do is you're either going to nail the humerus or you're going to end up being behind the glenohumeral joint. So it's an important kind of distinction, but I think it's something that we kind of just gloss over because we're so in tune of, oh yeah, there it is, stick it into the place where it needs to go. And unless you follow your needle with the ultrasound, you may end up missing that. So that's an important kind of caveat when you end up making this distinction. And then again, when you end up having these, just in terms of basically kind of labeling this, you're coming in basically from the lateral side. Basically, you have your humerus anteriorly depressed, and then you end up having your glenoid right here. And then this is basically you're going to be able to visualize the actual lidocaine going in. Now, I think there shouldn't be a huge amount of discrepancy about the amount and the dose of what you should be doing. Usually I use 1% lidocaine. I never use epi when I'm injecting a joint. I don't think that you want to end up causing any kind of vasoconstriction around that area. So these are always without epi. I usually use about 20 cc's, and this is coming in with the actual spinal needle coming into the actual the glenoid. Now, when you end up kind of making this, I want you to also notice where it's not going, right? This fluid is not extravasating superficially. It's not extravasating deep. You can see it pretty much all contained. So the next kind of point is that if you end up starting to see a little bit of an extravasation, just stop. Stop, basically reassess kind of how you're positioning, reassess where your needle point is, find your needle point if you don't know where your needle point is, and then basically reassess and then start over again. It's okay to give little squirts of lidocaine. Obviously you can see where it's going right over here. So if you have any kind of problems and you can't find it, then basically just you can give a little bit of a squirt of lidocaine to get an idea where you're at. It's been studied. I got nothing else to say about kind of the evidence. I think you guys kind of know it. Just in terms of doing the procedure, I'm not going to go into too much about the actual kind of technical component of it because I think you guys can pretty much all stick a needle where you need to be. I think the important point is to kind of find the area where you're going, right? And so if you've done them with me, again, it's going to be a 3.5-inch spinal. Just some tips to make sure, and this is just reiterating some things that I was saying before. Remember, if you're going deep in your ultrasound probe, that's actually anterior. So when you end up positioning, if you find that your probe is a little off center, if you need to go a little deeper on your ultrasound probe, that means you actually need to angle your positioning a little bit more anterior for your needle. And so that'll end up being an issue. Like I was saying, it's a 30-degree scapular plane, so make sure that you're not going basically in plane with the, in line with the coronal plane. What I didn't actually kind of say is it's okay to aspirate blood, right? This is essentially a hematoma block, okay? This is what all the orthopods are doing whenever they basically are going and injecting into a fracture. So you want to get blood, and actually if you haven't aspirated blood, you're probably not in the right position, because when you end up dislocating your shoulder, you're pretty much going to end up having some form of bleeding, and you will have some form of bleeding in the glenohumeral joint. So you should be basically getting at least a little bit back into your syringe. Most of the time you'll actually see the blood coming up into your, back into your syringe, almost like in Pulp Fiction. And again, you should be using a spinal needle. And that's pretty much with this lead going in for the glenohumeral joint injection and the intra-articular. Easy, right? We're moving on? Okay, good. All right. We don't see this lady too much. I think we have sometimes, I think we have the wrong demographic. I think this is kind of, I think more often than not, this isn't one of our usual things that we see, but most of the time we end up seeing patients with hip fractures, a lot of times due to trauma. Occasionally we don't see the little old lady with the fall, at least not as much as other emergency departments. But you guys kind of know this person as well, fell usually from a standing level position, and now they end up having a shortened externally rotated hip. Whenever you log roll it, it hurts. Whenever you press over the anterior capsule, you guys end up having, you can see it right here, you guys have an intertrochanteric hip fracture. So one of the things that often gets mentioned is basically how we're going to give anesthesia. You guys go ahead and either give the morphine, or we do what's become kind of the sexy thing to do right now is the fascia iliaca blocks. So this one is something that not everybody has probably done, or at least not as common as shoulders, because it seems like we get a lot more shoulders in the ER, at least in the CCT area. This is referred to usually as a 3-in-1 block, and I'll kind of explain that in just a minute, but essentially it's supposed to be the lateral femoral cutaneous, the femoral nerve, and the obturator nerve. It's got some study, it's been preliminarily studied in pediatrics. There's some reviews on it in adults, and it's fairly safe. It's indicated for a lot of different procedures, and essentially what I want you guys to kind of understand is that we're kind of going off into the realm of pain management and essentially regional guided anesthesia, and so we kind of talk about it as if this has been ours for a long time. This is actually stuff that's been done by anesthesia for a long time, and we're kind of basically taking bits and pieces of their procedures and applying them to our own patients. And so essentially what we're going to do is, most of these are actually for surgical procedures. Some of these are for post-operative patients, but obviously we're going to be doing these majority for hip fractures, and that's really what we're going to be using our procedures on. So when we do this 3-to-1 block, essentially what we're looking at is the femoral nerve, the lateral cutaneous nerve of the thigh, and the obturator nerve. And the idea is that you're going to be injecting along the plane of the femoral nerve, and the idea is that this block is actually going to end up running proximally. Now, we have here an anterior view of the hip, correct? So what you'll probably notice is that we're just hitting at the anterior nerves of the hip, and that'll be something that'll kind of be explained maybe a little bit later. But we have 3 nerves right over here in the hip. Now, if you'll remember, when you end up having the nerves that are supplying intra-articular supply to the hip and that are basically giving you innervation, you're going to end up having the nerve to the quadratus, the nerve to the quadratus femoris, and then you're also going to end up having a little bit of the sciatic, right? Sciatic focuses more on extensors, femoral nerve is going to focus more on flexors, obturator nerve is going to focus more on adductors, and so we're not actually getting the sciatic nerve, the nerve to the quadratus femoris in the back. We're basically just kind of focused on these. So your patients may not have complete elimination of their pain. Typically what ends up happening is that you'll get almost 100% block of the femoral nerve. Around 88% of the time you'll get, or excuse me, about 80 and 90% of the time you'll get basically block of the lateral femoral cutaneous nerve. And then very irregularly you'll get block of the obturator nerve, essentially as the fluid, excuse me, your lidocaine will actually extend proximally and end up innervating, will end up anesthetizing the lumbar plexus. So when we kind of look, first we're going to go femoral nerve. It's L2 and L4. It's going to pass on the psoas major. And I know that you're probably just being like, oh yeah, there's Valesky going off on more anatomy. You actually are going to need this for your ultrasound, so I just want you to kind of understand, like when I say psoas, psoas is going to become a very important landmark when you do these procedures. And then it's going to branch distally. Essentially, you're going to supply pretty much all of this area, or you're going to knock out all of this cutaneous innervation when you end up doing the femoral nerve. Your obturator nerve, like I said, that will actually be somewhat intermittently, and you'll get blocked sometimes intermittently when you do this. Again, this is going to be through the psoas major. And all of this, this nerve is actually going to run posterior to the arteries. It's going to run through the obturator foramen. And usually, cutaneous sensory innervation will be usually knocked out in the area medial to the medial on the medial thigh. Again, this is a little bit in the way that the nerve is running. Finally, the lateral femoral cutaneous nerve. It goes pretty much at the lateralmost point at the inguinal ligament, and it goes just underneath the inguinal ligament. If you guys remember correctly, meragem peristatica is something that gets affected with patients who end up having tight belts or big bellies. And essentially, it's going to run lateral to the iliacus muscle. So iliacus, iliopsoas, basically we kind of keep coming to these kind of points right here. This is where the lateral femoral cutaneous nerve ends up supplying. So if you guys remember this old thing from anatomy right over here, this is kind of where we're going to end up applying everything. So you end up seeing right over here, you have your lateral femoral cutaneous, you have your femoral nerve, you have your obturator foramen, which ends up having your obturator nerve. Here's the iliopsoas muscle. And again, that's kind of what you're going to be looking for when you end up doing this block. I want you to know one important thing right over here is that when you end up having a neurovascular bundle, the femoral nerve is actually in a different fascial plane, okay? And that's why this is referred to as a fascia iliaca block, because it's actually going to be deep to the fascia iliacus. And so when we end up kind of looking at this, and the reason why they say fascia lata and fascia iliaca is because you actually end up having two planes over here. You end up having basically, superficially you have a fascia lata. So obviously that's just the fascia that you're referring to. And the lata is referring to the tensor fascia lata. The fascia iliaca obviously is referring to the iliacus muscle. And deep to that, you'll end up seeing the femoral nerve, the lateral femoral cutaneous nerve, and then the idea is that our nerve is going to extend proximally whenever we end up making this injection to anesthetize the obturator nerve at the lumbar plexus. So when we end up looking at this through ultrasound, essentially what you're going to do is everybody should be able to find the femoral artery. It's not that hard. It's that thing that pulses right there. And remember what you have, however mnemonic you want to use to find navy, nerve, artery, vein. Somebody once said venous to the penis, although that's only applicable in 50% of your patients. But essentially what you're looking at is the nerve should be lateral, right? And so essentially what you end up having right here is the lateral bundle is going to be your iliopsoas muscle. And just superficial, you're going to see a little fine, bright white line. And that's going to be your fascia iliaca. Now, people have done this landmarks basically for a long period of time. And essentially what they look for, and you may read in the literature, is this double pop. Essentially what they're looking for is they're looking for kind of, or they're feeling for a pop going through the fascia lata and then through the fascia iliaca. There's an ultrasound, or at least there should be, in about every room in CCT, or excuse me, in the main ER, and then in downstate, you should have other ultrasounds, so you should be able to do this by ultrasound. If you want to do a landmark, we can always go through that, but you probably, for first starting out, you should try it by the ultrasound, and then if you feel a little bit confident, you can go through the other way if you get a little bit better at it. But essentially, that's what we're looking for, and this is essentially where we're going to end up placing the needle. It's not going to be an out-and-out nerve block, and the reason that we kind of just said is we're trying to knock out 3 nerves, and so essentially we're not going straight into the nerve, we're basically going into this fascia iliaca right over here, and in that way we're actually going to see extension of the block. And so when you end up placing your needle, you're going to, again, place your needle right here, and you're going to be just superficial to this iliopsoas muscle, and what you're going to try to get is a dissection of this fascial plane that you'll end up seeing. And we're going to try to go with some of the videos that we have, and then I have a stock video that shows it a little bit better because we actually don't have great videos in our ultrasound collection. And so this is kind of the area where I'd like for you to basically be looking at right now. And this isn't, sorry. And so essentially what you see is the artery, the vein, the artery. This is that crappy ultrasound that has that permanent shadow. And this is going to be where the nerve is, right here. And essentially, what this is trying to make out right over here is the iliopsoas muscle. And this is basically the needle kind of going in. And here you can kind of see this dissection along this fascial plane. And what will end up happening is you'll end up seeing this dissection go proximally, but obviously you want to see it more so go medially. Excuse me, you'll see it go laterally, but then you also want to see it go medially as well, because that'll give you the innervation of your femoral nerve. And then by that fact, it'll be allowed to go proximally and innervate your obturator. Now, I understand that these are pretty bad images, so there's a better one on YouTube, of course. So anyway, this is essentially what just happened to